Peripheral vascular diseases include peripheral arterial disease and peripheral venous disorders, both of which interfere with normal blood flow. PAD affects arteries, and that's the bloods that carry the blood away from the heart. And peripheral venous disease affects veins, and that's the vessels that bring blood back towards the heart. PAD is a result of atherosclerosis, and it usually occurs in arteries of the lower extremities. However, you can get it in your arms, and it is characterized by inadequate flow of blood. Atherosclerosis is caused by that gradual thickening of the intima and the media of the arteries, ultimately resulting in a progressive narrowing in the lumen of the vessel. Plaques form on the walls of the arteries and make it rough and fragile, and then we have platelet gang activity, and it tends to clump there, and then we have clots. Progressive stiffening of the arteries and narrowing of the lumen decreases the blood supply and to the affected tissues, and it increases resistance to blood flow. Atherosclerosis is actually a type of arteriosclerosis, which means hardening of the arteries, and alludes to the loss of the elasticity of the arteries over time due to the thickening of their wall. PAD is classified as an inflow, which is distal aorta and iliac arteries, or outflow, which is femoral, popliteal, and tibial artery, and it can range from mild to severe in nature. Tissue damage occurs below the arterial obstruction. Finally, Brugger's disease, subclavian steal syndrome, thoracic outlet syndrome, Raynaud's disease, and Raynaud's phenomena, and popliteal entrapment are examples of peripheral arterial disease. Our risk factors for PAD include hypertension, hyperlipidemia, diabetes, cigarette smoking, obesity, sedentary lifestyles, family, predisposition, and age. Older adults have a higher incidence of PAD. The rate of occurrence is increased in men over 45 and women who are postmenopausal, and also have a higher mortality rate from complication than younger individuals who have PAD. The signs and symptoms include this burning, cramping, and pain in the legs during exercise. That's intermittent claudication. That is the hallmark sign of peripheral arterial disease. There's a numbness or burning primarily in the feet when in bed. So when the feet are either at the level of the heart or above, that's when they have pain. And the pain is relieved when they put their legs in a dependent position. So this is where individuals who have peripheral arterial disease are much more comfortable when they are sitting in their lazy boy chair, up and around, but when they are lying flat, no flow. Gravity is not their friend. Gravity is their friend. They like the blood to go down, so when they become horizontal, gravity is not helping them out in perfusion. We see you could have a bruit over the femoral or arterial arteries, could occur from that turbulence because of the narrowing and obstruction. There is a decreased capillary refill in the toes, which is greater than 3 seconds. They could have diminished or no pulses at all in their distal pulses, distal to the obstruction, so their feet, it's hard to find pedal pulses. Loss of hair on the lower calf or ankle or foot. Non-essential tissue is not going to get oxygen. So hair growth is not essential. It's not going to get oxygen to grow hair. So they don't have hair on their legs. Their skin is scaly, dry. It could be mottled. Their toenails are all thick because of decreased perfusion. They may have a cool cyanotic extremity. And when they elevate their legs, they're whitish. When they put their legs down, they have that dependent rubor, so they become flushed and red. They could have muscle atrophy, and they may have ulcers and possible gangrene. And the ulcers are really demarcated, round, punched out looking, and nasty. Like they're typically over bony prominences. Heel could be on the knuckle of the toes. So over the bone, they'll have this punched out look. Okay, diagnostics for peripheral arterial disease, angiography. We're looking at the lower extremities, arterial injection of a contrast medium, and under fluoroscopy we look at the runoff of the arterial flow. And that's done only to determine isolated areas of occlusion that we can actually treat with a procedure. And typically, if we can use percutaneous transluminal angioplasty, so they will angioplasty open the vessel or put a stent in, just like they do in the heart, but now we're doing the lower extremity vessels. And in an acute peripheral arterial occlusion, if we have a fresh clot, they might actually give a thrombolytic to bust up that clot and restore flow distally to the clot. Nursing actions, the same as with the cardiac catheterization. Any type of angiography, we're going to be looking for bleeding or hemorrhage and palpation of the pedal pulses to assess for any post-procedure occlusion. We can do also stress tests, exercise tolerant tests with a treadmill or with not, using medications, dipyridamol, that's persantine, or adenosine, which is adenocard. It can be given to mimic the effects of exercise for someone who can't tolerate it. And then there's the measurement of the pulse volumes and blood pressures prior to and following the onset of symptoms or 5 minutes of exercise. And then there's going to be delay in return to normal pressures and waveforms, and they're looking at all that to evaluate the claudication. Plethysmography is used to determine the variation of blood passing through an artery and identifies abnormal arterial flow in the affected limb. And what they do is they put blood pressure cuffs attached to the upper extremities and the lower extremity, and then it's attached to a plethysmograph, the machine, and any variations in the peripheral pulses between the upper and lower extremities are recorded. So a decrease of pulse in the lower extremity indicates possible blockage in the leg. Then finally they do segmental systolic blood pressure measurements, and with a Doppler probe take various blood pressure measurements, the thigh, calf, ankle, brachial for comparison. And absence of peripheral arterial disease, pressures in the lower extremities are higher than those in the upper extremities. That's normal. So with arterial disease, pressures in the thigh, calf, and ankle are lower. So that's the measurement, and there's a calculation that's involved with that as well. Actually, these are great screening tools and very cheap. So what do we do for nursing care? We want to encourage our clients who have peripheral arterial disease to continue to exercise. Yes, they have intermittent claudication that's exercise induced, but we want them to build up their collateral circulation. So they initiate gradually and slowly increase. They walk till the point of pain, stop, rest, and then walk a little further. We want them to not to cross their legs when they're sitting, to avoid crossing their legs. Tell them to refrain from wearing restrictive garments. To elevate their legs to reduce any swelling, but not to elevate them above the level of their heart, because we know we still need that gravity in there to help perfusion. And extreme elevation is going to slow arterial flow. So just elevate them, but not to above the heart. We're going to promote vasodilation and avoid vasoconstriction. So a warm environment. Have them wear warm socks. Never apply direct heat to the affected extremity. They typically have decreased sensation and they may burn themselves. They want to avoid vasoconstriction, so avoid the cold. There's no other better reason than not to go outside in the winter. And we want to instruct them to avoid stress, caffeine, nicotine. Those are all vasoconstrictors. That can stop smoking, stop chewing tobacco. Because that is also vasoconstriction. And the vasoconstriction effects can last up to a whole hour after a cigarette smoked. So it's not just for a little bit, it lasts for an hour, that nicotine in there. Medications that we typically use: aspirin, acetylsalicylic acid, clopidogrel, which is Plavix, pentoxylene, which is Trental, and antiplatelet medications reduce the viscosity by decreasing the blood fibrinogen levels. They actually make the red cells more flexible so they can get around those little nooks and crannies inside the vessels, and they increase blood flow to the extremities. So they make them slippery, slidey, and bendy. Aspirin and Plavix can be prescribed. Trental sometimes it can be used. It was one of the first medications that came out, but it's used less commonly than Plavix and aspirin. Nursing consideration, these meds need to be given with meals, and it might take several weeks for the medication effects to take effect, the effect of the medication to take effect. We want to teach our patients to monitor for signs of bleeding and abdominal pain, coffee ground enemas, tarry stools. That's for GI bleed. We want to teach them about that. Surgical interventions for PAD. Well, I talked about the angioplasty already. They may go balloon them open or stent them open, and they can do laser-assisted angioplasty, where a laser probe is advanced through the cannula to the site of stenosis, and the laser is used to vaporize the plaque and open the artery. That's exciting. Actually, I've never seen that, but that's cool. So our nursing care for those patients, we want to make sure that we observe for signs and symptoms of bleeding at the puncture site, post-procedure, watch their vital signs, peripheral pulses, cap refill. They need to be bed rest with their limbs straight, just like a cardiac cath. If we're going into a femoral artery, we're going to do the same type of post-procedure care. If they used anticoagulant therapy during the procedure, we need to follow by antiplatelet therapy for 1 to 3 months. Arterial revascularization surgery is used with patients who have severe claudication, limb pain at rest, and who are at risk for losing their limb because of the poor arterial circulation. So they'll do bypass grafts. And what that does is it reroutes the circulation around the occlusion wherever it is. So it could be a femoral popliteal bypass, which is called a fempop graft, could be done. And depending where they're doing it will tell you the name of where the location of where the graft was placed. They can harvest and do an autologous graft from the patient themselves, or they use synthetic materials. Often they'll harvest the radial artery. Post-op, we want to maintain circulation to the repaired artery, so we're going to be checking pulses, circulation, sensation, movement. That's real important to maintain and to observe. We're going to compare between the two legs. Warmth, redness, edema of the affected limb should be present as a result of the blood flow, so it should immediately pink up and warm up. And we're going to monitor for them for pain. And it can be severe because we're reestablishing blood flow to an extremity that has not had blood flow. We're monitoring their blood pressure. We're looking for hypo and hypertension. If they are hypotensive, we could have an increased risk of clotting, or the graft could collapse. And hypertension, we have a risk of bleeding at the suture site. So we want to limit their bending from the hip and the knee to decrease risk of clot formation. So we're going to keep them pretty either laying down or upright. Not a lot of sitting around post-procedure. We're going to teach these patients to avoid crossing their legs, loose clothing, wound care, no smoking, cold temperatures cause vasoconstriction, foot care, important. We don't want them to get any kind of gangrene, so they need to keep their feet clean, dry, good fitting shoes, not to go barefoot, cut their toenails straight across, podiatrist referrals. Anyways, so we want to have really good foot care. Let's see, what else did I want to talk about? Complications. Oh, yes. Okay, graft occlusion. Nasty. We don't want that to happen. It is a very serious complication and often occurs within the first 24 hours. As soon as we see signs and symptoms of reduced pedal pulses, increased pain, change in color of the extremity, or temperature, we need to notify the surgeon immediately. We're going to be prepared to assist with the treatment. Typically, what they'll do is an emergency thrombectomy where they'll go in and remove the clot. They may go in and do that local interarterial thrombolytic therapy, like I said, with a clot buster infusion. And if they have an infusion going in, these patients are in the ICU and they are closely observed for bleeding. Another complication is compartment syndrome, and that's considered a medical emergency at all. The tissue pressure within a confined body space can restrict the blood flow, and then we have ischemia that will lead to irreversible tissue damage. The symptoms of compartment syndrome are tingling. The patient complains of tingling, numbness, worsening pain, edema, pain on passive movement, unequal pulses, and we want to immediately report that to the physician. We're going to loosen the dressings. We're going to prepare to assist for a fasciotomy where they actually split the tissue, and that can be necessary for further injury, just to prevent further injury, and to save the limb. Okay, let's talk about peripheral venous disorder now, and that is problems with the veins that interfere with adequate return of blood flow from the extremities. There are superficial and deep veins in the lower extremities that have valves that prevent backflow of blood as it returns to the heart, and the action of our skeletal muscles of the lower extremities during walking activities promotes venous return. The three peripheral venous disorders that nurses need to be familiar with are venous thromboembolism, VTE, venous insufficiency, and varicose veins. A VTE is a blood clot believed to form as a result of venous stasis, epithelial injury, or hypercoagulability, like hypercoagulation. Thrombus formation can lead to pulmonary embolism and is life-threatening. This is a DVT, but the current new term is VTE, which is venous thromboembolism. Thrombophlebitis refers to a thrombus that is associated with inflammation. Venous insufficiency is secondary to incompetent valves in the deep veins of the lower extremities, and that causes pooling of blood and dilation of veins. And the veins' inability to carry the fluid and waste from the lower extremities causes the swelling and edema and venous stasis ulcers, and in advanced cases we'll see cellulitis. Varicose veins are enlarged, twisted, superficial veins that may occur in any part of the body. However, they are most commonly observed in the lower extremities and in the esophagus. So what are the risk factors? Well, for VTE, hip surgery, knee surgery, and then this is interesting, an open prostatectomy, open prostate surgery, increases the risk for a VTE. Heart failure, immobility, pregnancy, and oral contraceptives. Venous insufficiency, sitting, standing in one position for a long period of time, obesity, pregnancy, and thrombophlebitis increases the risk for venous insufficiency. Varicose veins, someone who's over the age of 30 with an occupation requiring prolonged standing. Well, that would be nurses. Waitresses also get that, varicose veins, anyone who's up on their feet a lot. And then pregnancy, obesity, systemic diseases such as heart disease, and family history. Varicose veins run in the family. So what are the signs and symptoms? Limb pain. They all have pain, aching, feeling of fullness or a heaviness in the legs after standing. With DVT and thrombophlebitis, the VTE people, they can be asymptomatic. Classic signs of DVT and thrombophlebitis are calf or groin pain and tenderness and a sudden onset or swelling of the legs. Palpate the site for warmth, edema, induration, hardness over the affected vessel. You want to look at the area and compare it with the other limb, measure, record, compare the right and left calf, right and left thigh, any changes over time, look for localized edema, monitor the client for any shortness of breath, any kind of pulmonary embolism signs, chest pain, that feeling of impending doom, that would indicate that the clot had moved to the lungs. In venous insufficiency, there is stasis dermatitis, which is that brown discoloration around the ankles, and it can extend up into the calf, and it's relative to the level of insufficiency. There can be edema and venous stasis ulcers, and those are typically found around the ankle, and they're irregular in shape, where the arterial ulcers are punched out and demarcated. Venous ulcers are irregular. Varicose veins, they also have that aching, painful, dull. Distended superficial veins are visible just below the skin, and they are very tortuous in nature. For diagnostics, we have some lab tests, starting with the D-dimer test. It measures the fibrin degradation that's present in the blood produced by fibrinolysis. A positive D-dimer indicates the presence of the products in the body and indicates a thrombus formation has possibly occurred. Other diagnostics for DVT and thrombophlebitis, they can do a venous duplex ultrasound that uses high-frequency sound waves. It produces a real-time picture of blood flow through the vessel. They could do the impedance plethysmography, which can be used to determine the variations of blood passing through the vein, and it identifies abnormal venous flow in the affected limb. And if the above tests are negative, if those last two tests are negative, but they still suspect DVT, they're going to do a venogram where they put the contrast media material into the vein and use not ultrasound, they use X-ray and fluoroscopy to see it. With varicose veins, they use what they call the Trendelenburg test, and that we put the patient in a supine position with their legs elevated, and when the client sits up, the veins will fill from the proximal end of the varicosities if they're pregnant, if they're present. So when the client sits up, the veins will fill from the proximal end. Veins normally fill from the distal end. So they've got their legs in the air, they put them down, and if they fill proximally, there's varicosities. If they fill from the distal end, there are none. Okay, so nursing care of DVT and thrombophlebitis, we want to encourage rest, bed rest, elevation of the extremity above the level of the heart is prescribed. We don't want to use a knee gauge, we don't use a pillow. Intermittent or warm compresses can be prescribed. We don't want to massage the limb because we don't want to dislodge the thrombus and make it an embolus. They can use thigh-high compression or anti-embolized stockings if the physician orders it to reduce venous stasis and to assist with venous return. We want to possibly, the patient might end up having to have a vena cava filter put in, and that's a little filter that traps emboli and prevents it from reaching the heart and lungs. And that's in the inferior vena cava, and that's put in through the femoral vein. With venous insufficiency, we want to elevate their legs several times a day for at least 15 to 30 minutes. They should keep their feet approximately 6 inches elevated at night. Avoid crossing their legs, wearing any kind of constrictive clothing or stockings, and they should be wearing TED hose, compression stockings, and apply them after they've elevated their legs when the swelling is at its minimum. Okay, so the medication that we use for these patients with venous disorders include anticoagulants, unfractionated heparin, low molecular weighted heparin, that's Lovenox, warfarin. They could use thrombolytic therapy. That we've gone all over those before previously, so make sure that you review that. And the team members that are used for this care, if they have venous stasis ulcers, we're going to need long-term management. Wound care specialists will be involved with helping them. Therapeutic procedures for varicose veins include sclerotherapy, which is where they put this sclerotic irritant, a chemical solution is injected into the varicose vein. It produces a localized infection that will over time close the lumen of the vessel, and then it'll just collapse upon itself. For larger vessels, there's an incision and drainage of the trapped blood, and then they may need to be performed 2 or 3 weeks after each injection. They use pressure dressings there. With those, you want to make sure your patients are wearing elastic stockings, TED hose for prescribed times, and they are taking mild analgesics for the incisional pain. That's for the sclerotherapy. Now for vein stripping of varicose veins, it's actual removal of the veins that can't be treated with something that's less invasive. They pull those right off. So what typically is done pre-procedure, they mark the veins, evaluate the pulses, so that post-operatively you can compare between. And then afterwards, they have elastic bandages on their legs. We're going to look for bleeding through the elastic bandages and check for circulation, sensation, movement, edema, pulses. Keep their legs elevated and encourage range of motion exercises, and avoid they should be elevating their legs when sitting. We don't want to dangle them much. So they will also be wearing elastic stockings after the bandages are removed. They also do endovenous laser treatment for varicose veins, and laser fibers inserted into the vessel, and it's threaded to the involved area, and then heat from the laser closes the dilated vein. And then also radiofrequency energy application, where an electrode instead of a laser is inserted into the vessel, and it's treated, that scars and closes the dilated vein, and then it closes down on itself. Any complications of this would be obviously with venous stasis ulcers form over the ankle. They can be chronic, hard to heal. They often reoccur. They can actually lead to amputation or death. Isn't that amazing? You can actually die from your venous stasis ulcer. They may also have a neuropathy and may not feel as much discomfort as it looks like they should. So, nursing actions for that, we're occlusive hydrocolloid dressings on deep ulcers. They may actually go into the oxygen chambers. I can't think of the name of that thing right now. And for healing, wound care, definitely go to a wound care clinic. Pulmonary embolism is also a complication. When the thrombus is dislodged, it can become an embolus and lodge in a pulmonary vessel, which leads to obstruction of pulmonary blood flow, and then we have decreased oxygenation, hypoxia, and possibly death. So we want to observe our patients for signs and symptoms of a pulmonary embolism, which is a sudden onset of dyspnea, pleuritic chest pain, restlessness, apprehension, a feeling of impending doom. They may have hemoptysis, a cough, tachycardia, crackles. There may be a friction rub. This is an emergency situation. Call a physician immediately. Rapid response, oxygen therapy, ABGs, and we get everybody on board. Okay, aneurysms are a weakness in a section of a dilated artery that causes a widening or a ballooning in the wall of a blood vessel. They can occur in 2 forms. They can be saccular, which only affects one side of the artery, or they can be fusiform, which involves the complete circumference of the artery. 75% of aneurysms are abdominal aortic aneurysm. The dissection of an aneurysm can occur when the blood accumulates within the aortic wall, following a tear in the lining of the aorta, and that's usually because of hypertension. So this blood accumulates and creates a hematoma. How do we prevent this from happening? Stop smoking. It's related to aneurysms. Maintain appropriate weight and height for the frame of your body. Healthy diet, physical activity, control blood pressure, and regular monitoring, and take blood pressure medications if you need it. Uncontrolled blood pressure, number one cause. Risk factors: atherosclerosis, uncontrolled hypertension, like I just said, and tobacco use linked to it. And as we age, there's arterial stiffening caused by that loss of elastin in our artery walls. We have thickening in our intima, and progressive fibrosis in the media occurs, and therefore as we age, we are more prone to getting aneurysms and have a higher mortality rate from aneurysms than younger people. Signs and symptoms. Initially, people are asymptomatic. Often they're discovered ultrasounds. They're doing an ultrasound of the gallbladder, and they look over the aorta, and ooh, hey, look at that big old bulging out. So that's often how they're found. How they're found, just serendipitously. So, triple A's, most common related to atherosclerosis. They have a gnawing feeling in the abdomen, a flank or back pain. Thin people, if you put your hand over their belly, they would have a pulsating abdominal mass. You might be able to hear a bruit, and this is only going to be on thinner people. Big people, you're not going to hear it. Elevated blood pressure, if they have an aortic dissections, which we see that in Marfan syndrome. Remember I talked about that earlier, famous Marfan, Abe Lincoln. There is a sudden onset of tearing, ripping, stabbing, abdominal or back pain. They then go into hemovolemic shock, diaphoresis, nausea, vomiting, faintness, apprehension. They may lose their peripheral pulses. Their neurological deficits happen, hypotension, tachycardia. Rarely do patients, if they're not present in a facility, do they survive from an aortic dissection. Someone who dissects at home probably won't make it to the hospital. A thoracic aortic aneurysm, we're going to see coolness or cyanosis below, hoarseness. They might have shortness of breath. I think it's up in the thoracic cavity. They have an aneurysm up there. It's going to affect those surrounding structures. Hoarseness, shortness of breath, difficulty swallowing. They may have severe back pain. That's up scapular. There might be a decreased urinary output. That's distal to where the aneurysm would be, right? The thoracic aortic aneurysm is up on the arch. How do we diagnose this? Oh, that's my next slide. Tell you at the next slide. Okay, now I can tell you how they diagnose it. So we diagnose this with X-ray. It reveals this classic eggshell appearance of an aneurysm. They're often discovered, like I said, when they're looking for something else. CT scans and ultrasound helps to assess the size and location of the aneurysm, and they're often repeated over periods of time to monitor progression. When we're caring for these patients, we want to take their vital signs every 15 minutes until stable. We're going to watch for increased blood pressure. We don't want to increase the pressure. We don't want to rupture an aneurysm. We want to keep them in stable. We're going to assess for the onset, quality, duration, and severity of pain. Temperature, circulation, and function of all their extremities is important to monitor. We're going to look at their rhythms, make sure that they're connected to a cardiac monitor. Hemodynamic values, if we have a Swan-Ganz catheter in them. We're going to be watching their ABGs, their SaO2, electrolytes, CBC. We're going to be checking their hourly urine output. We want to make sure that they are putting out greater than 30 mils per hour, because we know that that is adequate renal perfusion if that's occurring. Think of the renal arteries that are coming off of that aorta. Is the aneurysm involved in that? Is it above or below, or are the renal arteries involved in there? So that's really important to pay attention to. Our renals are perfused right off of the aorta. Oxygen on them, we want to make sure they have IV access. any kind of meds that we want to give. All aneurysms can be life-threatening. They do need medical attention. We're going to be giving them antihypertensives. We want to keep that blood pressure of a systolic between 100 and 120. Everybody's going to get involved with this. The cardiologists, the radiologists. We're going to have vascular surgeons in. And for surgical repair, we do a AAA repair, which is a resection, excision of the aneurysm, and then placement of a synthetic graft inside it, so that what they sort of fillet open the aorta, and then they put the graft inside it, and then they wrap the old aneurysms or the aorta around it like a jacket, kind of like they put the hot dog inside the hot dog bun, if that you can get that image in your head. A rupturing aneurysm has to be repaired immediately. It's emergency. Aneurysms in abdominal aortic aneurysms 6 centimeters or greater can be managed with elective surgery. Mortality rates are 2 to 5% with electives and 50% with ruptured. So we do want to deal with these before they rupture. Our priority nursing interventions are monitoring the patient's pressures, their rhythm, their hemodynamics. These patients are in the ICU following surgery. Very frequent vital signs. We're checking pulses distal to the graft. We're going to avoid flexion of the graft. Keep the head below 45 degrees. You're not going to put a graft in their abdominal aorta and then sit them bolt upright. Not a good idea. Monitor and maintain normal blood pressure on these patients. Fluids, prescribed rates. They probably will be fluid overloaded initially, especially if it's a rupture. Maintain a warm environment. We're going to monitor their urinary output. We're going to do daily BUN creatinines, looking for any changes in their renal perfusion, because renal failure is a possibility. They clamped off that aorta to put that graft in there. They clamp off that aorta, we've stopped perfusion to the renals. So we've got to pay attention to what's going on there. Pain medication, huge surgery, bowel sounds. We're going to watch for abdominal distension. This patient's going to come back with NG tube in place as well. We want to decrease the risk of thromboembolism, so they're going to have sequential TEDs on, get them up, moving as much as possible. Signs and symptoms of infection we're looking for. Prophylactic antibiotics are given, and then we want to know if there's any signs of graft occlusion or rupture. We need to report those immediately. What would those signs be? Well, is there a change in the pulse? Is there a coolness of an extremity below the graft? White or blue in color? Any flank change? Any severe pain? Any abdominal distension? Decreased urine output? Often some of the older surgeons will have you measure the abdominal girth on a regular basis, just to make sure that nothing is growing in there. Leaking, it would grow, right? Okay, so we want to teach our patients avoid lifting post-operatively, adequate nutrition. We want protein for healing, vitamin C, A, zinc. We all want that to report healing. That's a traditional repair. There's a percutaneous aneurysm repair. Now this is so cool. It's an insertion of an endothelial stent graft, and it avoids that huge long incision, and it shortens the postoperative period. It's typically used for abdominal aortic aneurysms, but it can be used to repair a thoracic aneurysm as well. If you get an opportunity to see one in interventional radiology, it's very, very cool. Post-operative or post-procedure care, nursing care for these patients, just like an angiogram really, or a post-cardiac cath. We're doing pedal pulse checks, monitoring rates, rhythms. Patients will be NPO for that. They actually have incision in both groins, so it's that post-op care of keeping the limbs extended, not opening up that puncture site. If they have a thoracic aortic repair, that's similar to open heart surgery. If it's not done um, endovascularly, with an endograft. So if they're doing a surgical thoracic aortic repair, that's the patient's put on cardiopulmonary bypass. It's like an open heart. It's involved. Complications following a AAA repair or a thoracic aneurysm repair: obvious rupture, thrombus formation can form inside the aneurysm, and then if an emboli dislodges, we have the risks that happen with emboli.